It's a great honor to be able to moderate this session. I'm James Bucksbaum. I want to thank Juhan Robert for inviting me. This is a very special session because they've invited the very best experts in the world to guide us in how to do things correctly so we don't have to reinvent the wheel here in the United States. It's a session called Screening, Prevention, Treatment Around the World, and it truly is. So our very first speaker is going to be Dr. Arnoldo Riquleme, who's at the Catholic University of Chile. He's the world's expert in H. pylori and the gastric microbiome related to gastric cancer. He is a former president of the Pan American Gastroenterology Association, and he's at the Catholic University of Chile. Thank you.
Good morning, everyone. So it's my pleasure to be here to talk about gastric cancer screening in South America. I have a relief because in the program I was talking about South Korea. So I need to prepare this very rush. So I'm going to present my experience, which is not my own experience, or the collective experience of many people working in this field for the last 10 years. And also I'm going to highlight which is important in terms of the evidence that was presented for many of the experts before me. As an introduction, the prevalence of gastric cancer in Chile is 23 out of 100,000 inhabitants. Latin America has intermediate prevalence compared to Asian countries. So if you remember the presentation of Douglas Morgan, the information is very heterogeneous. So the Andes is important, not only Chile, also Peru, Ecuador, Colombia. And if you go to Mesoamerica, you have some spots in Guatemala and Costa Rica. However, incidence and early stage of gastric cancer detection is very low in Chile, and our mortality is nearly 90% at 5 years. I'm going to show you some positive information in the last 6 years based on our ECOS cohort. So based on this prevalence, there is a need of screening strategies to detect premalignant lesions through invasive, endoscopic, with or without biopsies. I'm going to talk about this later, and non-invasive strategies based on blood or stools. And the main idea is to stratify risk factors to target some specific people that are in higher risk compared to the normal population. So we are going to talk in this presentation about 3 levels. The non-invasive strategy, level 1, is based on blood samples. Non-invasive strategy, level 2, based on stools. And invasive strategy, level 3, endoscopy. For the first one, we are going to talk about non-invasive biomarkers. So here you have the Pelayo-Correa cascade, very well known for all the audience, and Blanca explained it perfectly. What we have as biomarkers are not perfect, but the main information is coming from pepsinogen 1 and 2 as a marker of gastric atrophy, but also antiparietal cells and anti-intrinsic factor as a marker of autoimmune gastritis. Ferritin is an interesting target. It appears in some articles, and we have unpublished data related to ferritin, probably linked to atrophy, to hyperchlorhydria, not as acute phase protein marker like ultrasensitive PCR, C-reactive protein, sorry. So for intestinal metaplasia, we have threefold factor and antigen 15-3. Ultrasensitive C-reactive protein as a marker of inflammation. And I skipped the information that we work with Alejandro Corvalán about reprimo-likes and microRNAs, because I think that we need to be focusing something that could be based on low-cost markers. So this is the pool sensitivity and specificity for GastroPanel, which is a combination of serology, pepsinogen 1 and 2, and gastrin 17. The utility of this marker is around 0.7 or 0.8 in terms of the ROC curve, so it's good, but it's not perfect. And if you have severe atrophy, the marker is much better, the performance. This is our experience in Chile. We use the serology for H. pylori combined with pepsinogen 1 and 2, and we add demographic variables. As you can see, the moderate improvement adding demographic variables for the diagnosis of gastric cancer, right up the figure of the ROC curve, and the effect adding demographic variables for the gastric atrophy is much lower. So it's more important to add demographic variables to detect gastric cancer rather than to improve the performance in terms of identifying atrophy or gastric intestinal metaplasia. Threefold factor is important because it's one of the markers for gastric intestinal metaplasia. The other one are more related to atrophy. And you can see here our experience is already published in terms of threefold factor. So the ROC curve is moderate, is 0.76 for gastric cancer. Sensitivity is not so good compared to specificity. But if you add pepsinogen 1 and 2 plus threefold factor, so the ROC curve is slightly better. What happened with this information? We thought that there is not a magic bullet. So you have some specific biomarkers that are good, sometimes good enough, but not perfect. And if you combine biomarkers to target every stage of the Pelayo-Correa's cascade, you could have an improvement in the performance of a combined non-invasive biomarkers. So this is what we work in the last 2 years with Alejandro Corvalán and many others here. We target the serology for H. pylori as the main target of the carcinogenic process, antiparietal cells, antibodies, pepsinogen for atrophy, threefold factor for metaplasia, and for the whole process, the C-reactive protein. You can see here that the ROC curves isolated are not so good, 0.6, 0.7. But what is interesting in these ROC curves is the C-reactive protein is much better, the performance in gastric cancer. If you combine all of this plus the demographic data, what we can see here is an important improvement in terms of the ROC curve for a high risk of lesion, so Olga 3-4 is our main target, dysplasia and gastric cancer. All combined, the area is 0.76. But if you go to high-grade dysplasia and gastric cancer, it's over 0.9. So if you add ferritin, the performance is much better. So I think this is going to be promising. Yesterday we have a presentation. We are in phase 3, so this is the discovery cohort, and we need to take some prospective validation cohorts to demonstrate that if the performance is still like this, like we can see here in the discovery cohort. We have, at the moment, 3 main cohorts that we are going to test this combination. And we are going to compare the multiple biomarkers compared to a simple combination of only IgG, H. pylori serology, plus pepsinogen 1 and 2 and demographic variables. So the other thing that is important is how we can get universal coverage for H. pylori detection. As a primary prevention, the most important thing is to detect and eradicate H. pylori. We have some cultural issues. I don't know if we have time. It's good to have this conversation because in Chile, the people they have no complaints if you want to take a blood sample, but it's very difficult to get stools. So what we thought is to have a combined strategy, to have a serology. We are going to perform a serology for H. pylori, which is good in terms of sensitivity. So if you move the cutoff value to 14, the sensitivity is going to be 95%. We are not saying that those patients, those subjects are already infected. So it's only to see which are the potential currently infected subjects that are going to require further demonstration of the infection. Could be UET, could be stools. The problem with UET is the cost. It's 10 times higher for us compared to stool antigens. So the idea is to have universal coverage over 45 years old based on serology, and we are going to continue with the strategy 2, taking stools of those patients. What could be interesting is to, if we are going to take stools in those patients, it could be double. So for us, it's opposite of the US. So for us, the main problem is gastric cancer, and the second one is colorectal cancer. If we are going to have stools, we can take stool antigens and plus FIT. We carried a survey with a panel of experts, including clinicians, including public health policers and policymakers. And the experts recommend to have the universal coverage for serology for H. pylori plus pacinogens and demographic variables, and then to test with the stool antigens only if the patients are serology positive. So test and treat strategy will be applied as a primary gastric cancer prevention, aligned with Maastricht Consensus recommendation for massive eradication in population like us, intermediate or high risk of gastric cancer. Chile has universal access to coverage of H. pylori treatment, so it's not a problem. If you have a positive test, the cost is free for patients in Chile. However, diagnosis is only for symptomatic patients, so this is going to amplify the extension of this coverage. We are working with Pan American Gastroenterology Organization, OPGE, in 2 projects, the HP LATAM register, which is very important to know which are good practices, to increase the number of the eradication rate for H. pylori, and to have a strong community moving forward of this infection. And the second one is HP RESLA, is based on resistance. Is antibiotic resistant a major problem in Latin America, particularly clarithromycin resistance, and we are going to perform DNA extraction from gastric biopsies recovered from rapid urease test. The HP LATAM register is already working. This is the first communication that we have from Chile, but we have many others from Argentina, Mexico, and Colombia coming the next year. And you can see here that, just for example, the quadruple therapy based concomitant or based on bismuth are the best in terms of the eradication rate, and is when we use high dose of amoxicillin plus metronidazole and bismuth, we have 97% of eradication rate. And the other thing that could be important is dual therapy, because it's 88% if you adjust by kilogram of weight. And this could be important if you are going to provide massive eradication in a population. If you use one antibiotic, but with good target, I think we are going to minimize the risk of development of antibiotic resistance. The third one, and it's the last part of my presentation, is invasive strategy. Level 3 is based on endoscopy. As Maria Blanca presented before, you can use 2 jars to separate antrum, angula, incisura angularis, and corpus, but we use this cassette that is a part of the figure illustrated there. It's important because it's very practical. You can use the same mapping process, but you put all the cassette, the plastic cassette, inside of just a single jar, and you have less cost. And if the pathologies of your country are available for that, I think this is going to be perfect. So we performed this since 2015 and it's working perfectly well. Then you can stratify in terms of Olga staging or OLGIM as you want. And this is the way that we work since 2014 in Chile, based on the Chilean Association Endoscopy recommendation. We perform upper endoscopy with these standards, and we take Sydney protocol biopsies. There are two main studies, the GCPL project, the NIH grant by Constanza Camargo in the south. I want to show some information, is in Nueva Imperial. And the other one is a longitudinal cohort called ECOS study based on our university hospital. The ECOS cohort with the Chilean flag is based on Olga. You can see here what is important in our experience is Massimo Rucci from Italy. They have this cohort based on a population with low risk, is 7 per 100,000 inhabitants. Italy is not a high risk country. However, they developed this process through Olga, and Olga 3 and 4 are at higher risk. But they said that Olga 0 to 2 are no risk at all. What you can see in the lower figure is in our survival curve that Olga 2 is intermediate, and Olga 0 is really no risk at all. So 1, 2 together, or only 2 are intermediate risk compared to 3 and 4. And the other one is the Singaporean cohort, is based on OLGIM, and you can see that the line is more exponential. Probably the risk of OLGIM is much higher compared to Olga, and this was what we present in DW last meeting, but now we have another analysis of the same cohort. And you can see here that Olga, if you use Olga 0 and 1 and compare it to Olga 2 and Olga 3 and 4, the hazard ratio is 5 times more if you see the curve for Olga 3 and 4. But if you see the same arrangement based on OLGIM, the OLGIM 3 and 4 is 24 times higher, the hazard ratio. So you need to take into consideration if you are going to follow for a national level Olga or OLGIM. Could work perfectly well both, but then we can talk with Maria Blanca or other pathologists, but what we think is OLGIM could be easier to implement, and the information will be clear because the kappa between the agreement between pathologists is much higher in OLGIM compared to Olga. Olga is more complicated, and sometimes you have this problem that you have Olga 2, but Maria Blanca says, oh, it's Olga 2, but could be higher risk because you have this or that. If you use OLGIM, probably it's going to be easier to do a more reliable follow-up for patients. This is the GCPL experience. Briefly, is a high-risk community in the south of Chile, Amerindian ethnicity. Is poor and rural area, restricted access to endoscopies, and what we support, because it was led by Alejandro Corbalán and Constanza Camargo. The Chilean Society of Gastroenterology support this with 88 endoscopies, which is nearly 20% of the whole community of endoscopies in Chile. And this was social accountability, no payment for that. It's just to help people with less resources. Nearly 2% of the population get an endoscopy, and the results are more than 50% of the population were Olga 1 to 4, so in some extent in risk, but only 15% are Olga 3 and 4. Is still high compared to other cohorts, but is feasible to do surveillance in 1 out of 8 subjects in this community. The important thing is If you use chromendoscopy and B0, the Yagi classification, the Japanese classification, was associated with Olga 0 in biopsies. So the negative predictive value is 90%, and those patients, if you are well trained, you can avoid biopsies and say, we're not going to spend money in biopsies. You can leave it like that, and no follow-up for those patients. 0.2% of gastric cancer and 66% were incipient or early stages. So we changed this paradigm that if you are in Chile, you will have a 90% of mortality because you are going to get late the endoscopy. This is not true, and if we see the information that I mentioned before in the ECOS cohort, is also promising because all the patients get curative resection, endoscopic or surgery, and all of them, in 600 patients follow-up in 7 years, all of them are alive. EGD can be used as an invasive universal strategy after 45 years old. However, endoscopy waiting list, symptomatic patient is a problem in Chile and other Latin American countries, particularly after COVID-19. So we have a delay, even in private sector, of 2 or 3 months for upper endoscopy, and could be 1 or 2 years in the public sector. It's not realistic to implement universal EGD coverage like Korea or Japan with our current endoscopic capacity. So the approach suggested for the Ministry of Health include a non-invasive strategy to optimize resources and prioritize access to EGD using serology plus demographic variables for both asymptomatic screening population and symptomatic EGD waiting list, because if you go to the waiting list and you perform the endoscopies, 2% or 3% are gastric cancer. So you are wasting resources if you follow some strategy with symptomatics and not the same one with asymptomatic or vice versa. As a conclusion, each stage of the premalignant cascade can be assessed with non-invasive biomarkers. Pepsinogen 1 and 2 is associated with gastric atrophy. Threefold factor could be used for as a non-invasive marker of gastric intestinal metaplasia, but none of these isolated are good enough to be used as a standard. So multiple low-cost non-invasive biomarkers combined with demographic variable is a promising approach, but prospective validation cohort will be the next step to widely promote it. Non-invasive strategy, blood and stools for over 40 years old was recommended by the National Expert Panel. For primary prevention will be based on H. pylori eradication, and invasive strategy will be applied for the same age in subject with intermediate or high-risk premalignant lesions or gastric cancer based on non-invasive biomarkers. At the moment, we prefer to assess premalignant lesions with biopsies during the EGD and follow up based on Olga and Olgim. Endoscopic follow-up for Olga 3-4 should be performed every 3 years because in the survival cohort, in the first and 2 years, not so many cases develop gastric cancer, and we have limited resources. So for that reason, we think that 3 years is okay for secondary prevention strategy. Collaborative projects with European and Latin American countries, H2020 legacy, and the future projects, including genomic and microbiome studies, will be offer new information about progressors and non-progressors to gastric cancer to elucidate this mechanism related to the progression to gastric cancer. OPGE and H. pylori microbiota gastric cancer Latin American study group were supporting these strategies and promote collaborative multicenter studies that we will be happy to talk later during the meeting. And the idea is to provide primary information from Latin America because most of the information are coming from East Asia. At the end, I want to invite you. We are going to have the Pan American Congress next year in Santiago de Chile. It's going to be in October 8 to 11, so save the date. We're going to be more than happy to receive you. And we are going to have 3 days of activities related to H. pylori, microbiota, and gastric cancer. This is my contact. Thank you so much.